Welcome to our channel. In this video, we'll be diving into the latest cutting-edge research presented at the ongoing ESICM Lives 2024 in Barcelona, one of the premier events in critical care medicine. The first study is leg cycle ergometry in critically ill patients. Introduction and background. Cycle ergometry is a rehabilitation strategy in the ICU, aims to mitigate post-ICU impairments by improving physical function. 33 RCTs, with 3,274 patients, included in the meta-analysis. Outcomes studied: physical function at ICU discharge, ICU and hospital length of stay, mortality and adverse events, efficacy of cycle ergometry, physical function improvement, ICU discharge, 12 RCTs, 1291 patients, SMD 0.33, 95% C, 0.05 to 0.62, low certainty. Post-hospital discharge, 8 RCTs, 865 patients, SMD 0.23, low certainty of evidence. Length of stay. ICU stay decreased by 1.06 days, low certainty of evidence. Hospital stay reduced by 1.48 days, moderate certainty. Safety. Mortality. No significant effect on ICU mortality, 17 RCTs, 2039 patients. Adverse events. Cycling intervention, 1% adverse event rate. Control group, 2% adverse event rate. Overall, cycle ergometry is safe with few adverse events. Conclusion. Cycle ergometry may improve physical function and reduce length of ICU and hospital stays. No significant impact on mortality or other major outcomes. Low risk of adverse events makes it a feasible rehabilitation strategy in ICU settings. The second is the JAMA study comparing alternative screening frequencies and spontaneous breathing trial, SBT, techniques for successful extubation. Introduction. Study objective. Compare effects of different screening frequencies and SBT techniques on the time to successful extubation. Design. 2x2 factorial randomized clinical trial involving 797 patients in 23 ICUs across North America. Interventions. Daily versus more frequent screening. Pressure-supported SBT versus T-piece SBT. Key results are: the primary outcome was time to successful extubation, time when spontaneous breathing began and was sustained for is greater than or equal to 48 hours. Median time to successful extubation, daily screening plus pressure support, 2.0 days. Daily screening plus T-piece, 3.1 days. Frequent screening plus pressure support, 3.9 days. Frequent screening plus T-piece, 2.9 days. Conclusion. Frequent screening with pressure-supported SBT led to slower extubation compared to daily screening. Pressure-supported SBT did not reduce time to extubation compared to T-piece when screening was done daily. Clinical implication. Further research is needed to explore these interactions and their impact on weaning from ventilation. Introduction. Objective. To determine if using a non-selective extracorporeal blood purification, EBP, device reduces the incidence of cardiac surgery-associated acute kidney injury, CSA-ACI, in high-risk patients undergoing cardiopulmonary bypass, CPB. Study design. Double-blind, randomized trial conducted in 2 tertiary hospitals in Spain. Participants. 343 patients randomized, 169 received EBP, 174 received standard care. Mean age, 69 years, 224 men and 119 women. Patients were at high risk for CSA-ACI, undergoing non-emergent cardiac surgery with expected CPB time greater than 90 minutes. Primary results. Primary outcome, incidence of CSA-ACI within 7 days. EBP group, 28.4%, 48 out of 169 patients, developed CSA-ACI. Standard care, 39.7%, 69 out of 174 patients, developed CSA-ACI. Statistical significance. Adjusted between group difference of 10.4%, p-value 0.01. Effectiveness. Reduction in CSA-ACI observed across multiple patient subgroups, including those with diabetes, chronic kidney disease, and low body mass index. Conclusion. EBP significantly reduced CSA-ACI within 7 days post-surgery, but did not improve long-term outcomes such as length of ICU stay or 90-day survival. Clinical relevance. EBP shows potential as a protective intervention against ACI in high-risk cardiac surgery patients. Further studies are needed to confirm these findings and assess long-term benefits. The final study is liberal versus restrictive transfusion strategies in patients with acute brain injury based on the TRAIN trial. Study objective: evaluate the impact of liberal versus restrictive blood transfusion strategies on neurological outcomes in patients with acute brain injury. Population: 820 patients, 444 men, 376 women, with traumatic brain injury, subarachnoid hemorrhage, or intracerebral hemorrhage. Mean age: 51 years. Hemoglobin levels less than 9 grams per deciliter at admission to ICU. Conducted across 72 ICUs worldwide. Key results are: intervention, liberal strategy, transfusion triggered by hemoglobin less than 9 grams per deciliter, 393 patients. Restrictive strategy, transfusion triggered by hemoglobin less than 7 grams per deciliter, 413 patients. Primary outcome: unfavorable neurological outcome at 180 days, Glasgow Outcome Scale Extended Score 1 to 5. Liberal strategy: 62.6% had an unfavorable outcome. Restrictive strategy: 72.6% had an unfavorable outcome. Adjusted relative risk, arranged by 0.86, p-value 0.002. Secondary outcomes: no significant differences in 28-day survival, 20.7% versus 22.5%, liberal versus restrictive. ICU or hospital length of stay, organ failure at 28 days. Adverse events: lower incidence of cerebral ischemic events in the liberal group, 8.8%, compared to the restrictive group, 13.5%. Conclusion: a liberal transfusion strategy reduced the incidence of unfavorable neurological outcomes at 180 days compared to a restrictive strategy. Clinical implication: liberal transfusion is a feasible intervention to improve long-term neurological outcomes in acute brain injury, though survival and other secondary outcomes were not impacted.